Hello class, my name is Andaya. I'm the instructor for Substance Abuse Fundamentals. Oscar Sita, the director of this program, has asked me to record a few lectures in relation to some fundamentals that you may need at this level of your education and the level of career or job experience that this level of education will afford you pretty soon. And so I spent quite a bit of time meditating on this, thinking about what concepts might be the most useful for you at this time of education and experience. And so I've boiled it down to 3 different concepts that I like to share with you today. And we'll get to those in just a second. I just want to give you a little bit of an introduction of myself first. So again, my name is Andaya. I'm a licensed substance abuse and mental health counselor in my city, Las Vegas, Nevada. I have a master's in mental health counseling. I'm currently in a doc program at the University of the Cumberlands in Kentucky for a PhD in leadership with specialization in counselor education and supervision. I work at an agency currently with mandated parole probation clients struggling with mental health and substance abuse, as well as with individuals affected by HIV positive diagnosis. I also work in private practice where I like to incorporate a lot of mindfulness-based techniques in my approach, which includes meditation, breathing exercises, and even light yoga poses, as I'm also a certified yoga instructor. And that's a little bit personal about me too, is that those are both my passions in life, is counseling as well as yoga. So to be able to bring those together in my daily work life is a real big blessing for me. And I share this with you because I hope that you're able to also find a way to incorporate your passions within your work life so as to make every day worthwhile. As you'll soon find out if you haven't already, there isn't a lot of money in counseling. So if that's the intention why you're doing this, then good luck to you. But if you're doing this because of some deeper value other than materialism, then I think you'll find this field very, very rewarding. So enough about that. Let's go ahead and move on into the concepts that I wanted to introduce to you today are going to be first the stages of use. Secondly, the stages of change. And thirdly, I want to introduce the term compassion in terms of treatment of those struggling with substance abuse or other addictive behavioral disorders. So let's start with stages of use. So I think society in general has this unrealistic idea about addiction. And I often hear this term from family or loved ones of those in recovery, especially early on in their recovery. They have this expectation of, why don't you just stop? Just stop using and everything will get better. And unfortunately, it's not that easy at the stage of addiction. And no one just wakes up one day and is addicted. There's a series of behaviors and steps and phases leading up to addiction. And so that's what the stages of use are. We'll start with the first stage, which is marked by no use. So at this stage, probably early on in childhood, the person does not have knowledge of what drugs exist, what they do, and so there is no use. But as the hallmark of adolescence and early adulthood, developmental stages start to appear, curiosity and experimentation tends to be quite common at this stage of development. And so that's experimenting to see what different drugs do. And the use could definitely stop there if there's, an adverse reaction to these drugs. But depending on different factors, like stressors is a major factor, genetic factors, environmental stressors, relationship problems, financial, socioeconomic status, gender identity issues. The more of these risk factors are in place, the likelihood of an individual who is in the curiosity or experimentation stage of use to progress to more habitual use. So maybe only using when going to a party or on the weekends, or maybe habituation could look like a few beers after work, or a few glasses of wine after work, or one hit here, one line here and there, right? So it's habitual in the sense that the person is no longer, just running into these substances like in curiosity experimentation, but they know where to find them and they're seeking these substances out. There isn't quite any negative consequences acquired just yet. It's just, going out and seeking these substances. Again, we could stay at the stage of use, habitual use, or with all those other factors previously listed, the likelihood, the higher the stressors, the higher the likelihood of continuing to the next stage of change or use, which is the stage of abuse. So abuse of a substance is marked by continuing to use despite negative consequences that have been acquired because of the use. So negative consequences could be relationship problems. Somebody's very concerned about the use, and it's now causing a lot of arguments and instability, maybe lying, hiding, manipulating, things of that sort. It could be related to employment, like calling in late, calling in completely, or going to work hungover or intoxicated, and then getting, whether you got caught or not, that you weren't at your best and whatnot. It could be legal consequences, such as a DWI or a DUI, or even domestic violence that happened under the use or abuse of a substance. So legal consequences. They could be financial consequences, spending large amounts of money on this substance and not taking care of everyday responsibilities. So continuing to use despite negative consequences is what marks abuse. Now, when we get to the final stage, addiction, we're talking not in addition to the negative consequences that are acquired, the individual continues to use this harmful substance no longer out of a desire to feel good, to escape reality, but more so out of a need to feel normal. And so what I'm referring to are the terms withdrawal and tolerance. And so when you put a substance into the body, say 5 days a week or every single day on a daily basis for whatever length of time, say it was 1 year, my body, my physical tissue is going to become dependent on that substance, meaning that if you don't give it that substance, it'll start to maybe shake or sweat or become restless and pacing, or depending on the substance, I might start to become nauseous and vomiting and diarrhea. And these are all withdrawal symptoms, meaning that the body is wanting more of that substance, and it's going through these detoxifying withdrawals, asking, demanding for that substance back. And so that's what marks the difference between, just being able to stop, which was probably possible at the social or habitual stage of use, at the curiosity, definitely, but at the stage of abuse or addiction, specifically with addiction, it becomes a lot harder because there's a lot of medical concerns related to detoxing. So from working in inpatient facilities, I can tell you firsthand that the most deadly withdrawal symptoms come from chronic alcohol addiction or abuse, and also benzos like Xanax, Valium, things of that sort. So any of those sedatives. So the withdrawal symptoms for these are the most severe. They could lead to seizures, dehydration, brain aneurysms. They can be very deadly. Whereas withdrawal symptoms for opioids oftentimes are extremely uncomfortable. I've seen people, shaking and going into psychotic episodes because it's just part of the withdrawal process, and delirium and nausea and diarrhea. But it's questionable, sometimes I doubt whether that research is necessarily up to date, that opioids are not as deadly, don't cause as deadly withdrawals as benzos and alcohol, but I do know that most insurances would not pay for inpatient opioid detox. They would refer them on an outpatient basis, which means you'd get a medication, go home, and then you're kind of on your own at that point. If symptoms get severe, you're recommended to go to an emergency room and whatnot. But to detox in an inpatient facility where you're monitored 24/7 by nurses and doctors for some reason is not something that insurance would pay for. That might have something to do with the opioid epidemic and just how prevalent this disease is and how expensive it's getting for insurance companies and for the country in general. But those are just some, side personal and professional thoughts, not so much related to this lecture. So we'll continue. So the next concept I want to introduce to you is the stages of change. So these are pre-contemplation, contemplation, preparation, action, and maintenance. And so at the pre-contemplation stage of change, somebody who is maybe abusing or using socially, or even at the dependent stage of use, does not really either want to know or doesn't really know the negative consequences of their use. So either they really don't know, or they avoid maybe looking at that pamphlet at the doctor's office, or when the conversation starts to lead in that direction with someone, they might change the topic or, eject themselves from the conversation altogether. So there's a lot of denial involved in the pre-contemplation stage of change. Whereas the contemplation stage of change, the person is now weighing the pros and the cons of not using anymore. And people can stay in this stage for years or months. It's a very individualized process. And the theory is that, the more that the scale starts to tip one way, hopefully in the direction of no longer using, that the person will then move into the preparation stage of change. So at this stage of change, the individual is not completely committed to, abstinence or sobriety, but they're cutting down. Maybe instead of 5 times a week, it's 3 times a week. Maybe instead of spending a certain amount of money a week, they spend a little bit amount a week. Maybe they go from smoking to snorting to swallowing. This preparation stage of change, I've seen people kind of cycle through this a few times. They'll go to preparation, but unfortunately that leads to like a full-blown relapse, and then they go back to pre-contemplation, and then a few months later contemplation, and they're back at preparation. And sometimes it takes a few cycles of going through this to finally get to the action stage of change, which is, intentionally not consuming the substance, engaging in a recovery program, whatever that means to the individual, whether it's professional help or peer support through NA, AA, CMA, or whatever that recovery program might look like. It might just look like individual therapy in addition to AA, or it might be like an intensive outpatient program, 12 hours a week, or a partial hospitalization program, 20 hours a week, or it varies per individual. Again, depending on different factors as far as the age of onset has a lot to do with the severity of the use. The earlier the onset, typically the more severe the addiction. The route of administration has a lot to do with determining how severe the addiction is. So you probably already know, but obviously IV would be the most severe, quickest route to the brain barrier and penetrating into the brain. So once you're at the IV stage of use, have progressed, usually goes from pills to pills, swallowing, snorting, smoking, and eventually, leads to IV use in terms of those types of drugs. Obviously, alcohol has only one route of administration, but that even can change in severity also, the amount. And all those factors also relate to alcohol, like the age of first use has a lot to do with how severe that addiction will be. And so in terms of the stages of change, we talked about pre-contemplation, contemplation, preparation, and action stage of change. Once you get into the field, if you're going to continue to, go to a master's program and become therapists or counselors, eventually teachers, you want to be able to tailor your interventions appropriate to the individual they're all going to be at different stages of change. So we'll get to that at the last part during the case study section. But the last term I wanted to introduce to you is this concept of compassion in the treatment of substance abuse disorders and even behavioral addictions, which, by the way, the newest form of the DSM, which is coming, I believe, in either 2018 or 2019, but don't quote me on that year, is likely going to list online gaming as a disorder, behavioral disorder. just a side note. But this concept of compassion, the treatment of substance abuse and other behavioral addictions, it's, I think, one of the most fundamental pieces that I could relate to you at this level of your education and careers. It is probably also the most important that if you can stay true to this concept, to this, way of heart, this value throughout the rest of your careers, then I think you will have affected a lot more lives than if you didn't practice this value, this verb, this way of being. And so this concept of compassion, I want to differentiate it from sympathy. Sympathy is feeling sorry for someone. And believe me, clients who struggle with addiction do not want to be felt sorry for. Typically, if they do want you to feel sorry for them, in my professional experience, it's because they want to manipulate you in some way and get something out of you in terms of money or a ride or don't kick me out of the program or something along those lines. So sympathy and compassion are not equal. Okay, compassion and empathy, very similar but also not equal. Empathy is the ability to feel what somebody else is feeling, to understand their perspective on life. Compassion asks for you to do that, in addition to compassionate interventions to tailor the way you're going to treat this individual appropriately to how they're feeling and what they think in that moment. And so, for example, if I have a client who maybe, this is actually a real client I have now, so I'll leave out the names, but say 45-year-old Hispanic male, currently on parole, multiple felonies, not all drug charges, but all kind of related to the addiction. So, stealing, robbing, gang-affiliated violence, all kind of tying back to this addiction. This individual grew up in very low socioeconomic status, started abusing alcohol, then progressing, alcohol and marijuana, and then at the age of 14, at the age of 17, started abusing meth, eventually found heroin in about mid-20s, and since then, now 43 years old, has been on and off abusing just about all those substances. Primary drug of choice, we could say, is heroin, because that's the one he has the physical withdrawals from the most severe. So with this individual, it would be very, very easy to judge him based on all of those factors, right? The criminal charges, maybe, this guy has been this client has been in treatments facilities more than 2 handfuls of times. And so it would be very easy to throw hands up and say, I give up. This client's going to have to hit rock bottom. Nothing I can do for him. If he hasn't changed now, he's never going to change. And so I think it's pretty obvious to see that the compassion in that is lacking. But to see this person, instead, to choose to see this person through a different lens, a more professional, educated, compassionate lens, would be to see that he's had all these stressors and factors working against him, and that he's still trying, even though this might be his 11th or 12th time trying. He might not yet still be at the action stage of change. He might be sober because, or abstinent from the drugs and alcohol because he's on parole. And maybe he will end up going back to using after he gets off parole. But while you have him in treatment for whatever amount of time, he is sober and thinking somewhat clearer than he would be if he was out on the streets abusing drugs and alcohol. So while you have them for that period of time, it is important to start pointing out the negative consequences of using and building those up in their mind, in the back of their mind, continuously reminding them. Because in the forefront of their mind, they're probably, or even in the back of their mind, they're already thinking, fantasizing and romanticizing the idea of using. And so our job as counselors becomes then to point out the negative consequences of their use in a very compassionate and sensitive way. And everybody's approach is a little bit different. Some people use humor, some people are very direct, some people use analogies and stories. You can use a little bit of everything, right? And so another case study I wanted to bring up to you is also a current client of mine, which is a 52-year-old Caucasian woman. She is a stay-at-home mom and has been abusing alcohol on and off for the past 10 years. So her pattern of use is more like binge use, which then leads to abuse. And so this client specifically, has raised 3 beautiful children who are almost all adult, with the exception of one. She is very intelligent and presents physically very well put together and polite, has a master's degree, so she's very educated. Is at the action stage of change in terms of she knows that she has a problem. She continuously abuses alcohol, even though there's negative consequences in her relationship, financially, in her character. Now she's lying and hiding and manipulating. Daily chores aren't getting done, and the children are suffering, in their relationships with their mother. So she has these negative consequences. And for some, it might actually be easier to have compassion for her than it would to have compassion for the 43-year-old ex-felon client. And so what I'm trying to say with these case studies is that it is important to treat all clients equal in terms of how we view them through the lens of addiction, through the stages of change, the stages of use. We view them all equally through that lens, but at the same time we individualize our approaches and interventions and treatment approaches to that specific individual. So the client, the female client, she is already at the action stage of change. So I don't need to continuously remind her about the negative consequences of her use. She is well aware of them. Now what I have to work on with her is to make sure she has recovery plan in place, healthy coping skills, healthy activities, healthy relationships, and start working towards wellness so as to maintain her sobriety and abstinence, which is the maintenance stage of change. I don't think that we covered that one. And she didn't start drinking until early 30s. So her brain was fully developed. The human brain, stops developing, the research says, about mid-20s or so. And so her brain was already fully developed. And she, socioeconomics, is higher on the socioeconomic status ladder. She has family and friends as support system. So she has all these strengths that are working for her. Whereas the other client, although it's a lot easier to judge him, was not afforded these types of luxuries in life. A healthy support system, fair parents, also addicted, siblings, also addicted, community he lives in. It's very common to see addiction, gang-related affiliation, all of that. And so I guess when I'm talking about compassion, I want to point out that culture, gender identity, socioeconomic status, all those factors play a role in addiction. And so to take a more holistic approach at addiction, it's important for us to remember that. And so that's all I have for you today. I hope that you're enjoying your semester thus far, and best of luck on the midterm. Just so you know, none of this content on the video will be on the midterm, but it will be required for the discussion forum. All right, well, until next time.